All right, we're gonna get started. We have many questions here. As I sort through this, I'm gonna start with a question on Vanko. So the question is Vanko effective in patients with PSC without IBD? So that can go to Dr. Davies or James.
So all of our patients have had IBD that we've treated. So I don't know if you've treated anybody without IBD. And then that becomes a little bit questionable on whether or not is it truly PSC or is there a bit of an overlap syndrome on those patients. But all of our patients that we've treated, the 79 patients on vancomycin all had IBD.
I think excellent question. I know in our clinical trial, 30% of patients did not have IBD, but then if you take 30% of a randomized arm that only has about 9 patients in it, we're talking very, very small numbers. We tried to look at the data and try to make some meaningful inferences, but I don't think we were able to. I would say, though, that I think if vancomycin works, it probably could work in a patient who has PSC alone, not to mention since some patients who are thought to have PSC only actually also have IBD. It's just very, very quiescent, and we haven't perhaps looked hard enough for it or don't have the tools to detect it.
All right, so we have multiple questions on Vanko, as expected. So the other question is, what is the long-term safety of Vanko in patients who are worried about developing resistant bacteria, particularly in a setting of perhaps immunosuppression used for IBD? So what do you think the safety profile is?
So we haven't had any side effects on oral vancomycin. We haven't had any patients select out for VRE. I would say, again, the oldest patient that we have on vancomycin is 25 years. I think there's multiple patients in here that are on vancomycin. Some of you guys have been on it 11 plus, 7 as I look around the room and see you, with 0 side effects on those patients. None of our patients, although I'd say some of our patients out of state that we've treated in combination with other physicians have remained on their immunosuppressants, and those patients haven't had any issues. But none of our primary patients that we've managed from the beginning have been on anything other than just vancomycin.
Okay. So switching the question tone, so to Dr. Medici, what is the benefit of green tea, perhaps in PSC, and also if coffee, should it be decaf or regular? How much?
Okay, so for the coffee, so it's for sure caffeine as a beneficial role, but it's also other components. And there are thousands of components in coffee. So if you want to take decaffeinated coffee, it's still beneficial. With caffeine, probably there are more benefits. So do you know anything? So that it's how much? It's hard to tell. Obviously, it has to be black coffee, so sugar and all of that. It's just coffee. 1 or 2 cups a day, that will be just sufficient. For green tea, I know there are some benefit in general for patients with liver disease. No big data, but I don't think it's going to be for sure harmful. I don't know if you have any comments on that.
Okay. So another question for the URSO debaters. Is there data indicating that there is a benefit of URSO on fibrosis and also portal hypertension as suggested on our talk?
So there was one study that I had mentioned at the end that looked at paired biopsy results, and that in smaller trials there was some benefit in terms of patients that were started very early in their disease course, potentially not progressing as fast and not developing fibrosis as fast as those that were not started in the placebo arm. So there is a thought that it can potentially slow the progression of fibrosis if it's started early on. And then the other question was portal hypertension. So I think that in general we all believe that if you already have signs of portal hypertension, it probably won't reverse it, and it likely is not going to be much of a benefit to use at that point. But in terms of preventing the fibrosis and ultimate development of portal hypertension, that I think started early on, there's a thought that it could potentially help, and it's worth trying then.
Okay, so another question on URSO. Is there a benefit of URSO in preventing recurrent PSC after transplant? Chris, do you want to-
So I'm not a transplanter, but there is some data, although like everything we talk about here, the quality of the data is not great. There's some work out of France, I believe it's Switzerland, where centers treated patients differently. Some got it, some didn't. Actually, that's PBC, I'm sorry. But in PBC, there's some data on that. In PSC, I'm not aware of data in terms of after transplant.
So the risk of recurrent PSC, I think Dr. Guy is going to talk about this in her talk. I don't know if she's here yet, but the risk of recurrent PSC post-transplant, within a few years is. The risk of recurrent PSC after transplant within 5 years is decent. Between 10 to 20% of patients will develop recurrence, and that's a little bit higher than other autoimmune conditions, but it does happen post-transplant. So we don't necessarily start ursodiol immediately post-transplant unless there's other high-risk biliary complications. So if you got a living donor, potentially you'd be on ursodiol, or if there was any issues in terms of the anastomosis to the bile ducts post-transplant, then you would be potentially put on ursodiol. More importantly, though, in order to prevent the recurrence, it's actually that we use higher doses of immunosuppression post-transplant, and most people are always on dual immunosuppression, so needing potentially long-term steroids, or at least having both tacrolimus and Cellcept on board over the long run. And that's what we use to normally prevent it.
So I'm going to add my own question to James and perhaps Dr. Davis. So there are some alternative or integrative medicine providers that are actually profiling a stool microbiota using a stool DNA assay, and based on the microbiology or the microbiota profiles, I would recommend different type of diet. So are you aware of that, or do you think, are we ready to kind of profile a stool microbiota and recommend treatment at this time? So I think that would be to James and Dr. Medici, I meant.
That's, excellent question. I think maybe many of us have had patients who might come with printouts of maybe complementary and alternative medicine providers' testing reports. And a lot of times we look at them without a whole lot of credence. We don't necessarily put a whole lot of confidence in them. But I think there is something there. I don't, in other words, I do think that fecal profiling can provide many interesting revelations. But I don't know that any of us are ready to say, oh, well, your XYZ company fecal microbiome report showed this, so we're going to put you on this diet because that's going to correct this problem. I think I don't know that we're quite there yet, but I do think that we are heading in a direction of precision medicine, and that might mean that for a given PSC patient who has a given preponderance of this bacteria, but a marked deficiency of another set of bacteria, maybe we can provide a more tailored intervention, whether it's an antibiotic, a probiotic, or some other diet.
If I could just mention, I think you all got an email about a study we're doing, which is exactly trying to get at this, and this is very early days. We wouldn't know what to give people to change their microbiome. We don't know what is, the problem with the microbiome in detail, and so some of the work that James and I are doing is to determine within patients with PSC, what are the correlations between specific nutrients that people are taking, their liver disease, the bile acids in the stool, and the microbes there. And so hopefully getting some idea of what those correlations are, and then how we might target diet to alter it in a positive way. But we're at ground zero here. We've got a long way to go.
I have to comment that I do have patients that are actually with that change in diet, which could be probiotics, prebiotics, and again, I don't understand what each profile means, but they're actually feeling better and with even improved alkaline phosphatase. So, I would love to contribute to your study. We have patients that are interested. Another question, maybe Chris, you can answer this. Can you compare URSO with NOR-UDCA and its role in treating PSC?
So NOR-URSO is a closely related chemical to URSO. It's got a little bit different properties in terms of how it's handled by the biliary system, and is thought to promote a protective layer around the bile ducts and be more effective than URSO itself. And there's been a phase 2 study completed recently in Europe. It's a drug only available or produced by a company, a small company, family-owned pharmaceutical company in Europe. So it's only been studied there. And in the phase 2 study, it did show a significant decrease in alkaline phosphatase in patients that received the drug at 2 different doses compared to placebo. So it met its primary endpoint. And when they looked at the effect of NOR-URSO in patients that were taking URSO versus those that weren't taking URSO, they still saw a benefit of NOR-URSO. So it does appear that it has a benefit above and beyond what URSO is offering. And that drug is going into phase 3 studies. I think probably Dr. Amit will be talking about that later today. And I think one of the feelings in the research community right now is that treatment of PSC is going to be more than just one drug. So it may be URSO and or NOR-URSO, and then a whole host of other drugs, maybe we'll discuss later, that can regulate bile acids.
Okay. So this brings up another interesting question. So as we all know, there was a study where patients that were stable on URSO for some time, and that was discontinued. In looking at their liver biochemistry, I think 3 months after discontinuation, there was a significant flare in all the labs, and including symptoms such as worsening of pruritus that some people had to go back on treatment. So here I have a patient who states that small duct PSC, I've been on URSO with normal liver enzymes for years. Should I stop or continue? So that would be Chris and Aparna.
I wouldn't rock the boat. I'd keep it as it is.
Do you think that is a kind of rebound effect, or do we have any data showing that that elevation was sustained more than the study period? I think James, you had editorial on that.
Yeah, I remember there were, I don't think we have much longer data beyond 3 months post-discontinuation to say is it really rebound or not, but I remember there were some patients in that study who the symptoms that came back, that recrudesced, were so severe that they had to be put back on URSO, and the symptoms went away again. So if you look at some of the criteria we use to, for example, for drug-induced liver injury, it's important to see if you can recreate the problem if you re-challenge a patient with that same drug. So if you think of the inverse, in this case, the problem was created when the drug was taken away. It seems like the drug was given back, the problem went away again. And I think even changing the subject a little bit with some of the vancomycin work, at least in pediatrics, Dr. Davies would probably agree that I think a similar observation was made where some patients who responded, Vanko was taken away, and then they did poorly again, were restarted on Vanko, they did better again. So I think I'm personally an URSO believer, if you will, but as both Dr. Goel and Dr. Bowlus mentioned, I don't think it's a panacea. It's only a certain fraction of patients who will respond. Just like if we take a very simple example of headache, some people, Tylenol will make their headache go away. Other people, it won't. That doesn't mean Tylenol doesn't work. It just means for that person, for that problem, it may not work. And the same thing can be said in inflammatory bowel disease with infliximab, with Remicade. It only works in about 40-45% of people. That doesn't mean that it should be taken off the market and it's a terrible drug. It just means you have to pair it with the right patient.
Okay. Another question about the microbiome. Is the microbiome a result of our genetic makeup, or is it influenced by external factors? And are there things that I can change to improve the profile?
Yes. So the microbiome is influenced by your genetics, whether you were delivered vaginally or by cesarean section, whether you smoke, by medications, by your diet, by who you live with, where you were born, what lake you or body of water you live by. I mean, there's so many variables in it, some of which you can manipulate, but many of which you can't. You know, if you look at the fecal microbiome transfers and things like that, they may change the microbiome, but oftentimes it reverts back after a period of months. So there's a lot of complex things going on that establish the microbiome, and some things we can do to manipulate it. But obviously genetics are a little bit harder to change.
Sure. So in terms of diet recommendation, I think this is for Dr. Medici. Do you have different recommendations for patients that are vegetarian or vegan?
No, I really don't have different recommendations. I mean, it's again, it's about the proteins. As I was saying, for patients that are vegan, vitamin B12 deficiency can be an issue. So make sure you check on that. And B12 comes primarily from meats, and so that may need to be supplemented. But otherwise, I wouldn't say any specific recommendation. No, just yeah.
And can you comment on benefits of bone broths, and the other one is milk thistle, and management of liver diseases?
Yeah. So bone broth, is it?
Bone broth is
bone
the
broth.
new
Yeah,
thing,
I think no specific recommendation. I guess, I mean, if there is a lot of salt in there, just be careful with that. I have definitely something to say about milk thistle. That doesn't work. So there is a lot of data out of there for patients with liver disease in general. We have even meta-analysis. It's not harmful, but it won't provide any benefit. So you can definitely save your money in that sense.
So another question, it says that, can you say that my liver is not being damaged when my labs are normal while on ERSO, or will there be any risk of progression of the underlying disease?
So I think that this was part of the discussion that Dr. Bowlus and I were trying to mention, that even in some people that do have normalization, so if you do have normalization of alkaline phosphatase, it is a good marker and it's a good sign, but that's not to say that your disease will certainly not progress, so that you're not at risk down the line of developing some of the other complications from PSC, including malignancies. So by no means does it mean that you should stop your medications when you're on them, but it also means that you do have to continue getting the screening exams and making sure that you do follow up for those. So it's a good sign, but it doesn't necessarily put you in the clear that you're not at risk for progression in the future.
Okay. Well, I guess this is another question about what were the specific brands of Vanko, Dr. Davies, you recommended. I think the slides would be available.
Yeah, so the brand now, vancomycin, the brand that we use now that works is ANI, A-N-I. They actually also put out a generic that's available, produced by ANI. It's actually the generic with just the brand with just a generic label on it.
So the other question is, are there studies that are ongoing on Vanko in adults? And I may ask if he knows this. Do we have the result of that study conducted at Stanford? And where do we stand? Does anybody know?
So there was, yeah, I can answer this really quickly. So Dr. Cox, who Dr. Davies works with, did study oral vancomycin in the adult population, and he is working with Dr. Shamita Shah, who's down in Oshner, and they have, it has not been published yet, but they do have a sample of adult populations that was studied with oral vancomycin post-transplant to prevent recurrence of disease. And I don't actually have like the full data to share with you, but it is in the process of being published, is my understanding. I don't know if you have anything updated.
There's also a study being planned by Keith Lindor, funded by the FDA. They're waiting to get it launched. So that will be coming up in adults, hopefully in the near future.
Okay. So I guess another question that I may ask for the panel is, given the variability of response that we are seeing with Vanko, some people have benefit and some don't, is there a specific patient profile or phenotype that may benefit from Vanko, and how is that going to affect your future clinical trial setup? I think that's the challenge in PSC.
So I worked with Shamita Shah at Stanford, and we ran a side-by-side study. And so I took care of the pediatric patients, and she did the study on the adult patients. And what we find is, because this is obviously a progressive disease, and those that I see with pediatric disease, there's less progression of the disease. So in fact, the majority of our patients have a normal MRCP. And so, which is not what you find in the adult population, where the majority of them have elevated alk-phos levels and MRCPs, which are abnormal, which as that progresses, there's more disease change, and there's probably more change in the microbiome that affects the disease. So we know that in early stage disease, those patients have responded to the vancomycin, but it's less responsive in more progressive disease. And so I think that is probably one of the differences on oral vancomycin out there. And then the other difference is not using either the correct dosing of the vancomycin or not the correct brand. And so we've had patients that have been on just twice a day dosing with not complete resolution, and once we correct that, then things improve. So we will look at this study side by side in adults and pediatrics on the microflora on the fecal transplant studies.
So there is a question on fecal microbiota transplant and PSC, and can you discuss the anticipated benefit? Is there a study coming up? I think you were just alluding to that.
We just got the data back on just our pre-Vanko patients and looking at their gut flora. We'll work with OpenBiome. This will be funded by Finch Therapeutics to look at then transplanting, doing a fecal transplant on the pediatric patients, as well as doing a fecal transplant on adult patients. And so we are right now in the works of finalizing the details of that study, and then we'll launch that.
So I just want to say that PSC Partners is actually funding a trial at Mass General by Dr. Allegretti to study fecal microbiome transplants in PSC. In fact, it was, I think, highlighted on the Vice whatever series. And so that's ongoing. There are studies on fecal transplantation and IBD already published. The results are, I would say, less than spectacular at this time. So there's still a long way to go.
So the other question is, again, multiple questions on concern for long-term consequences of using antibiotics in VRE. There is a patient stated that he had VRE positivity. Should I be placed on Vanko or not?
If the question was whether or not if they had VRE at the time?
This is a person that had VRE before and is wondering if he should avoid Vanko.
That's tough. I mean, that hasn't come up with us. I think, and we haven't selected out for it. I think that, that patient would have to look at where they stand at that point and the risks and the benefits at that point. But that is definitely a tough question to.
So the question was define VRE. So VRE, is vancomycin a resistant enterococcus, not bacteria. So it makes it hard to use Vanko. Build your resistant profile. It would be difficult to use Vanko as treatment in the future. So the other question on Vanko is, does Vanko treat the liver disease in the bile duct, or is the benefit in the colon or the microbiome?
So the patients that we've treated so far, in fact, so these 13 patients that we just looked at, their histology improved on vancomycin. So it wasn't, as the panel suggested before, it's not just getting normal labs and clinical improvement, but making sure there's no progression of the disease. And so the patients have shown that there was, of the 13 patients, the majority of them did show improvement histologically. Once they're on the MRCPs, once there's bile duct narrowing or strictures, we don't see progression. We haven't seen progression, but we also have not seen improvement because that is now a scar that's developed on those patients. So things have remained stable on those patients. Clinically, the patients have all improved that didn't have progressive disease.
Another question is there a potential role of Vanko in preventing recurrent PSC or treating? I have to say that I come across a case report that actually showed that there was benefit. I'm currently taking care of a patient with recurrent PSC.
Yeah.
So how much data do we have post-transplant recurrent PSC?
We have four patients. There's actually one here today. She's a post-transplant patient that remains 11 years on vancomycin post her recurrence of disease. But I don't think it's been used quite a lot post-transplant, so I don't think there's still a lot of data out there.
I don't think it would prevent recurrence, but I think if you develop recurrence, then there are some very few reports, but very encouraging ones that it could be similarly effective as it would be pre-transplant.
Okay. So another question on microbiome. Is a microbiome in PSC, I think James might have described this, different from the general population, and how is that different and what are the implications?
Yeah, it certainly does appear to be different. There's less overall diversity in the types of bacteria that are present, and bacteria is just scratching the surface of really what's in the intestine or in the colon, because there's also innumerable viral organisms and fungi as well. So it is different in terms of how diverse the bacteria are, going back to just focusing on bacteria, and also the proportions of bacteria. Some bacteria seem to be overrepresented, some seem to be underrepresented. There are hypotheses that maybe the overrepresented bacteria are the ones that might produce a metabolite or a substance that is injurious, and similarly the ones that are underrepresented might be the ones that would be important in immunotolerance, or in decreasing inflammation. It's still an area of I think, great pursuit.
Okay. So another question is, Vanko is not absorbable through the gut, and how does it work if it doesn't? Is this a topical effect?
Yeah. We think so, yes. We've measured vancomycin in the patients that we've treated with active disease and active inflammation in their gut. And so, like I mentioned, the patients that we have taken care of personally and diagnosed all had IBD. And so they didn't have vancomycin levels in them. And so we know it's not absorbed, but likely changes the gut flora or changes a bacteria that is affecting the immunity.
So another question about antibiotics. Rifampin seems to be beneficial in treating pruritus and PSC, and why have we not studied that in terms of treating the underlying disease?
So rifampin is an antibiotic, but the reason we use it for itching is because one of the side effects of it is to induce a bile acid transporter that gets things out of the liver that's causing the pruritus, not because it's having any effect on our microbiome or anything else. And I don't think there's any data from anywhere suggesting that it has any impact on, or any good impact, I should say, on liver tests or things that we might suspect mean a better outcome. So there's no evidence, I think, with rifampin at this time.
So I'm gonna one or two questions. Chris, I have a question about, so you mentioned that a drug, if not proven safe and effective, should not be used. Do you think that holds for a disease such as PSC, where the disease is rare, the outcomes takes years, and rather than saying that the drug doesn't work, should we think about spending time more figuring out surrogate outcomes, which I think the community is?
Yeah, I think there's okay. This is why these issues are so hard, is, if this was, a headache, as James was talking about, that would be a little easier to make decisions about this. But we're talking a disease that, has some potentially serious consequences, unfortunately, and that progression takes many years. So doing trials in this disease are incredibly difficult. So, and as we were talking about earlier, we don't have the ideal surrogate markers like alkaline phosphatase. So that's really where the field needs to go, is to develop these surrogate markers that can help us predict how people are doing. Now, overall, I would say that in medicine, we can make errors in omission and commission. And so it may be that not prescribing urso or vanco is an error of omission. We should be prescribing it when we're not, but we don't know. And the other option is we could be errors of commission. We could be prescribing it when there's actually harm being done. And my point of view is that as I said, we have to assume a drug is guilty until proven innocent, and this has been seen over and over again. And I'll admit that by not prescribing either of these two drugs in a patient, I may be making an error. I don't know, and none of us will know in this, and that's really the hard choices that we're making. And so despite some of the evidence that's being presented here, I think we also have to look at the level of the evidence. We're talking about case reports in a lot of instances. We're talking about sort of post hoc analysis of large studies that weren't designed to answer the questions that are being asked. Until we have, I think, a little bit better data, even though this is a difficult disease with very little therapies to offer, we have to be careful in the decisions we make in terms of using these drugs.
Okay. So I'm told that our session is up. I would like to thank all the speakers for great presentations and